Hello, and good evening. My name is Lisa Klaslow. I am with the Lupus Society of Illinois. I'm the Community Relationship Manager. Welcome to tonight's Q&A with the Rush Lupus Clinic presented by Dr. Cherney and Dr. Nika. Before we get started, I am going to make just a few announcements because I know people are probably just logging in now. The first one is about today's presentation. This event is for educational and informational purposes only and serve to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not be substituted or replaced by a medical expert care. Before making changes to your medical care, consult your qualified healthcare professional familiar with your medical condition and health status. LSI, we will be doing one more Facebook Live event for Lupus Awareness Month. It's Resources for the Lupus Community. This will be held on May 30th from 6 to 7. Mari Gonzalez will be the presenter. If you want, you can register for it or just hop on Facebook that night to join us. Sorry, the graphic seems to be missing from the slide, but we do have a Spanish-speaking lupus event coming up in Pilsen on June 15th. For more information, check out the LSI website. It is 6 to 8 p.m. in the evening, and dinner will be provided. It is fully in Spanish, and the presenter is Dr. Irene Blanco. LSI is 50 years old this year, so we are celebrating our anniversary all year round. If you have any great photos, memories, or just want to congratulate us, please send those over to Mary or me and check out our website. You can add them on there as well, and we'd like to share and highlight all your great memories. Tonight's presentation is made by people like you, donations. We really appreciate all the donations we get over the years, so thank you so much, and you can always go on our website, lupusil.org/donate, to make a donation. The Lupus Walks are back. This year, LSI will be hosting 2 5Ks, one in the western suburbs in Naperville area on August 12th. And then we have our Chicago Lupus Walk and Fun Run in Lincoln Park on September 30th. Registration's open, and we encourage you to come out, bring your friends and family for a great day of fun. If you are interested in being part of the walk planning committee, please contact me at 312-542-0002. We do have committees for each walk to make them special and personalized. So we hope that you will join us. Lupus charity runners will be running the Chicago Marathon. This year we have 30 runners who will be out there in October. If you are interested in becoming a lupus charity runner, please contact Mary at lupusil.org or call 312-542-0002 for more information about our program. Volunteer and internship opportunities. If you are interested in volunteering at one of our walks or upcoming events, or if you want an internship with LSI, please contact me to get more information. All right, and then before we get started, I'll tell you a little bit about tonight's presentation. So it's about the Rush Lupus Clinic, Rush Experience in Lupus Care, World Leaders in Improving Quality of Life. Rush Rheumatologists and the Rush Lupus Clinic are national and internationally known for their research on patient-related outcomes, which include identifying and prioritizing every patient's specific health concerns. For instance, you may not be concerned about relieving your lupus-related rash, while other lupus patients may mostly want relief from chronic pain, or you may want to ensure you have a safe pregnancy. Rush physicians take into account your priorities when developing your personalized treatment plan. They aim to take care of all your health issues and symptoms. Focus first on what's most important to you. With that being said, I'm going to welcome Dr. Cherney and Dr. Nika. We want to thank everyone who submitted their questions ahead of time, and we'll start going through the Q&A. At the end, if we do have a few extra minutes, you could comment. Otherwise, we'll have to get back to your answers at another point. Okay, so first question. What level of protein in urine is considered serious? Time to see a kidney specialist.
Thank you, Lisa, for the introduction, and we'll alternate some of these questions, and I'll handle the first one, which is actually a pretty simple one. We do have a threshold we usually use in our clinics. So how we check this is we usually check a urine test, and we measure how much protein is in the urine, which you can actually do over a 24-hour collection or actually just on a one-time urine sample. And the number that we get concerned about is usually over 500 milligrams of protein in the urine per day, or 0.5 grams of protein in the day. You can have kidney lupus at a lower threshold than that. Traditionally, we don't get concerned unless we see numbers above that. So that's really the answer: 0.5 grams per day or 500 milligrams per day.
Okay. Is it dangerous to be taking hydroxychloroquine for a long period of time? This comes from someone who's been on it for 8 years.
Hi, Lisa, and also thank you. I'd like to thank you and LSI for organizing these wonderful events. Very nice way to get in touch with patients. So, okay, as far as that question, I'm Dr. Nika. Okay, so is it dangerous to be taking hydroxychloroquine for a long time? Well, the hydroxychloroquine is a very safe drug. With cumulative use over the years, the risk of the main side effects, which is retinal toxicity, toxicity of the eye, is a little bit higher the longer we've used that. So we recommend that every year we see an eye doctor, and they do a special exam to look at the back of the eye and see if there is any changes. So 8 years, 10 years, it doesn't make any, there is no cutoff. So it doesn't make any difference for how long have you been on hydroxychloroquine, as long as you're up to date with the doctor's exams every year, and the dose of hydroxychloroquine shouldn't exceed what is the recommended 5 milligrams per kg for body weight. So your doctor should be aware of it, either rheumatologist or ophthalmologist, of the dose of the hydroxychloroquine you're on, and it shouldn't be a problem.
Okay. The next question is similar, but it says, are there any known ramifications for taking it for a long time?
So that's pretty much the answer to that question as well. So in terms of a long-term thing of cumulative toxicity, so something that over time the risk of it goes up, then it's really retinal toxicity is number 1, 2, 3, 4, and 5 on the list of things that we would actually watch for and get concerned about. There's very rare side effects that can happen with hydroxychloroquine otherwise. Those are not necessarily thought to be dependent on how long you've been on it or the dose that you've been on. Things like skin discoloration or hyperpigmentation, like darkening of the skin. Very, very rare other side effects I won't care to mention because I don't want to scare you away from what is a very good medicine actually for lupus.
All right. Do any special diets help with lupus? Like example, vegan, gluten-free?
There is no specific special lupus diets. In general, we say a healthy diet is a good diet for any autoinflammatory condition or lupus. So high in protein, low in carbs, anti-inflammatory diet, Mediterranean diet, but it doesn't have any specific restrictions. It doesn't necessarily have to be vegan or gluten-free.
Okay. How do you know if you're in remission from lupus?
So that's a great question. And I think a lot of lupus experts themselves are constantly shifting the definition of what that means. There's 2 pretty important and slightly different definitions that are used right now. And one is essentially a simple one to understand. That would be remission off medications. Essentially, no signs or symptoms of lupus. The labs don't show anything, and you're not needing any medications, including even hydroxychloroquine or Plaquenil. We'd call that basically the drug-free remission. And then much more common than that is what we actually shoot for, because it isn't very easy to get someone into remission without needing any medications on a longer-term basis. And that would be basically remission on a drug, whether it's on something as simple as Plaquenil or that and any other combination of lupus medications. And essentially, we're using the same clinical definition, which is to say someone doesn't really have any significant signs or symptoms, and their labs that will trend for lupus activity will not show any activity. So those are the 2 definitions. On or off a drug, it's really no symptoms, no signs, and labs are quiet.
Okay. Is remission predictable at all?
Well, lupus itself is a very unpredictable medical condition. You know, it can have periods of long quiescence and then all of a sudden can flare. So it's a relapsing remitting condition. So it's very hard to predict if someone is going to go into remission. But that being said, we monitor with blood work very frequently, every 3 months. If someone has, you know, active lupus, a little less if the lupus has been quiet. But if we see that the labs are in a good trend, they're quiet, they've been quiet for a long time, then we're optimistic that perhaps someone can reach a remission state.
Should my rheumatologist recommend a specialist, a nephritis or neurologist, or should I try to find one on my own?
So this might be related to a later question as well, but what I would say is, in my own clinical practice, I usually prefer that a patient ask me with regards to a specialty, whether, first of all, a referral seems like it really should be made, or whether, you know, you would go see that specialist and they wouldn't tell you anything useful about your lupus. And specifically also like which specialist, because truly, as you can see, even within rheumatology, there's some of us that may take care of more specialized diseases, lupus, for example, with Dr. Nika, Dr. Jolly, and I. And similarly, we'll know a network of people, especially for organs that lupus traditionally hits. So the kidney doctors, the heart doctors, the brain doctors, and orthopedists for people who have joint involvement. There are people who have maybe more interest in lupus, and sometimes that delivers a little better and more in-depth opinion. So traditionally, if you go through your lupus expert, then you're going to access those people a little easier, and it's probably a better way to go about it than on your own. Not to say that if you had someone in mind that you shouldn't bring that person's name up to your doctor and get their opinion.
Okay. I think that makes sense because then the doctors can get the charts and know each other a little bit too. So you have your own, group of doctors.
It's true.
All right. How important is adherence to medications?
That's an excellent question. We cannot stress this enough, how important it is, the adherence to medications. So first of all, we have to be honest with each other. The doctor with the patient have to have a trusting relationship. So we have to discuss this freely without any concerns, especially with a doctor, because if we see that lupus is not in a desirable state, is not in remission, is active, and we don't know if someone is adherent or not to the medication, why would we intensify treatment or add any other drugs? So adherence is number one. The longer you take the more regularly you take the medication, the higher the likelihood of achieving remission or achieving a steady state when lupus is quiet. These medications don't work in a short-term basis. You have to create a steady level in the blood, so you have to take the medications. They have a half-life, that they last in the bloodstream. So if you don't take the medication for a period of time, or if you miss medication, that blood level drops and the medication is not doing what they're supposed to do. It's not trying to control the disease. Without the adherence, it's kind of impossible. So that's extremely important.
All right. What do you think of the relatively new lupus drug, Benlysta, Locinus, and Safenello? I hope I said those right. And then you find those drugs helpful?
They're both the same.
Right.
To pronounce, and they're new, a lot of them. What I would say is I'd probably try to answer each one of these a little bit separately so that you can get my opinion about either one. And then Dr. Nika, also feel free to jump in with your own opinion and practice with these new drugs. So these are all drugs that, they're actually used for different sort of purposes. I'll kind of cover that. With regards to the oldest of them, which is not an old medicine, but one you may even be familiar with, some of you could even be on, it's Benlysta or belimumab. This is a therapy that was designed specifically with lupus in mind and has been around for over 10 years. And we know it as being probably one of what we kind of use as a more moderate medication for different aspects of lupus. And many of the sort of classic features of lupus will respond to it. So rashes and joint pains and sores in the mouth, and sometimes other aspects like having fluid around your heart. We'll sometimes even use it as an add-on therapy in kidney disease. It's probably not the very best choice for someone who has really severe and life-threatening disease all on its own, though can be considered as an adjunctive therapy. It's a medicine that is now basically time-tested and that we use regularly and occupies a role right in the mid-level. So I mean mid-level. So pretty much everyone gets Plaquenil if they can and if they can tolerate it, because it's a great medicine. It's very low intensity and prevents a lot of bad things from happening. And then there's medicines more in the moderate range, which we use and have used for a long time, things like mycophenolate, which is also known as Cellcept, or azathioprine, which is known as Imuran. It's somewhere in that range. It's given as an IV drug once a month, or it can be given at home as an injection. And so this one is, like I said, it's for a more moderate presentation of lupus, and that one has at least like 10 years of real use behind it. If we're talking about the other two, they are really new, actually. So loop kinase is voclosporin, and that is a medicine that was approved a few years ago, and its role is really specifically kidney lupus. So right now, where it's shown great effect actually is in kidney lupus that hasn't really responded to a lot of other different medications that we use. And it's a logistically kind of burdensome medication. It's not that difficult to get necessarily because it's an FDA-approved medication, but it's a bunch of pills that you have to take actually. And the class that it occupies, which is known as the calcineurin inhibitors, some of you may even ended up on a relative of it called tacrolimus. There's a lot of monitoring required, things like kidney function and blood pressures. It makes it a little bit logistically burdensome to use, as well as the number of pills, because think about it. I mean, a lupus patient's already taking like 10 pills just to have lupus for the most part. So this is a medicine I don't have as much experience with. I've seen used in 1 or 2 lupus patients in our practice, usually ones with severe kidney lupus, and that's specifically the role for it. The last one, Safnilo or anifrolumab, is another therapeutic made with the mechanisms of lupus in mind. And so this is something that blocks a pathway that's inflammatory called the interferon pathway. And this is the latest approval, and it is a medicine that is approved by the FDA for moderate to severe lupus, where I've used it, I think, once so far in my own practice. But overall, it's starting to be used more often. It is probably like where I would say it seems to be great is the skin. It seems to be quite good at the skin and rashes, all sorts of lupus manifestations. It's pretty good at the joints. It maybe doesn't have as much backing for internal organ lupus as some of the big gun medicines that we use. I think its eventual role, at least at this point, is it's something comparable to Benlysta that works in a totally different way. Benlysta or Benlimumab, which I just talked about. And this is a medicine that I think is going to gain some favor because basically it's something that works in a different way than everything else. And certainly lupus patients still need options of therapeutics. For a long time, we only had a few of them. So these are all medicines that are good. They're all approved, which means you can get them. Sometimes at variable costs. And 2 of them, like I said, have a more moderate role in lupus. And the third one's really for kidney lupus. And I'll welcome any input from Dr. Nika as well, as far as her experience with any of these drugs.
Yes, so yeah, I would second you about that, especially with loop kinase, which is specifically for lupus nephritis, and it's an add-on therapy to the standard of care. So you're adding this medication to someone that is already taking mycophenolate, is taking hydroxychloroquine, is taking a bunch of other medication. The starting dose is 6 tablets a day. So personally, I've never prescribed this. I see it prescribed more by the nephrologist, by the kidney doctor, specifically because it's designed to help with the kidney disease. And we're fortunate to have an excellent group of physicians, nephrologists at Rush. So I haven't prescribed that. I've seen it used in a couple of patients, but monitoring this medication can be challenging, like Dr. Charney said. Benlysta, again, it's a great drug. It's been around for a long time. I have a lot of patients, great personal experience, works for many different organ systems, and it has built up great data about, using lupus. And Safnello seems to be promising. It hasn't been around for too long. It's been mainly like a little over a year. So, but in my personal experience, I've had great results with the skin, with the joints, just like Dr. Cherney mentioned.
Okay. Well, thank you. When should I contact my rheumatologist office if I'm not feeling well between appointments? Like, for instance, if I have the flu, a fever, migraine, etc.
Great question. So I would say you don't feel shy to contact the rheumatologist, especially the rheumatologist. If you have lupus, you tend to develop a very great relationship with the rheumatologist because it's a chronic condition. We're seeing each other a lot. But if something happened in between the appointments that you're not able to answer yourself, that concerns you beyond something simple, you should definitely reach out to the doctor. It could be related to the condition itself, the lupus, or it could be related to the medication or the combination of two. So especially if you have some concerns about possible infection, fevers, of course, you definitely should let the doctor know. If there is something else like migraine, I'm not sure how to answer that. Sometimes lupus can cause lupus headaches. That tends to be in patients that don't have migraine. So I don't know if migraine itself, we can say or do anything about it. But it's nice to get in touch with the rheumatologist or get in touch with the doctor. So perhaps discuss a few aspects and try to sort out if it's lupus related, medication related, or something else that might not be. So yes, any concern that you cannot answer that you are worried about, you can reach out between appointments.
Is there any connection between cancer and lupus, and do any of the lupus medications increase cancer risk?
So another really good question. And part of this answer, as far as the first part of the question, connection between lupus and cancer, is also sort of generalizable to other autoimmune diseases or other chronic inflammatory states where your immune system is creating extra inflammation that shouldn't be there because it's targeting one of your tissues. We tend to think that there is a higher risk of cancer in those patients in general, which is kind of the argument for treating a lot of those patients on a longer term basis. So what we see traditionally is that cancer risk is somewhat attenuated if we're talking about treating inflammation back to the normal level that an average person would have. And if we're talking about specific cancers that maybe have been known to pop up, I think that one that is maybe underappreciated in patients a patient population who has lupus, which is young women. I think cervical cancer is an underappreciated specific type of cancer. It's pretty common and more common than it is for the rest of the population, the healthy rest of the population, to get abnormal pap smears and early cervical cancers and things like that than it is, like I said, for the average person. So screening for cancers, which is done in people in general, you have mammography, you have pap smears. In men, you have prostate exams. And then there's like colonoscopies later in life and that kind of thing. We don't necessarily recommend it more often routinely, but we do recommend that you get it and that you be pretty diligent about it in the settings where we can check for it. And otherwise, it's the argument for treating lupus. As to the second part of the question, which is also a really good one, is do lupus medications, are they either associated with or do they cause a cancer? And what I tell you about that part of it is any one of our lupus medicines, except for Plaquenil, are probably associated with a very occasionally observed extra cancer compared to the population. How I like to try to explain that to people is that it's difficult to say that it's definitively causing a lot of cancer. But if you were to take a group of people on, let's say, mycophenolate or azathioprine or any one of our medications, I'll talk about one after that's very strongly associated, but and you were to compare them to a pool of people who don't have lupus and aren't on the treatment, you would probably notice a couple extra cancers of various types in those patients. So if someone already has a cancer and is getting treated for it, we're a little scared about using our medications in that context. But traditionally, the effect is one in several, like thousands of patients who take the medicine. So we would probably see more cancers from untreated lupus than we would from treating the lupus with our medications, if that makes sense. And I will touch on one medicine that some of you may have been exposed to or know about, which is cyclophosphamide. That's the chemotherapeutic level treatment, the big gun, the silver bullet for lupus. And if you need that, your lupus is bad. And that is very well known to be, first of all, it's a chemotherapy. And as such, it's also it puts you at risk of developing cancers down the line. We try to minimize people's exposure to this early in life, because sometimes what happens is you get the treatment and it treats your lupus, and 20, 30 years later, you could possibly develop either a bladder cancer or another one. This is one that we are careful with for that reason. The rest of them, yeah, like I said, it's a theoretical concern, but probably of very little significance unless you have an active cancer.
Okay. All right, next question. Do men with lupus have to be concerned with reproductive issues from the disease or medications?
This is a good question. I don't think, men, as we know, lupus is more common in women. In men, it's less common. When it happens, it can be severe. But there is no direct correlation between reproductive system in men and lupus that's more commonly found in women through different mechanisms like antiphospholipid antibodies and all this that can cause miscarriages and can cause pregnancy-related concern. But as far as the reproductive issues, I don't think that concerns men as much. And as far as the medication, a lot of the medications we use for lupus tend to cross the placenta or cause different problems, and we try to avoid during pregnancy. But as far as the reproductive, Dr. Cherney mentioned cyclophosphamide, the big gum for lupus that we use for very severe lupus nephritis or other severe manifestation of lupus, tend to affect the ovaries in women, not as much, that I'm aware of. It can affect the men. And I don't know, Dr. Cherney, if you have any information. You prepared a whole presentation on men with lupus. So I'm not so sure if there is any direct correlation between lupus and the medication and reproductive issues in men.
I mean, we still have some level of concern with regards to long-term reproductive health if you get a lot of cyclophosphamide from,
right.
But really, practically speaking, mostly we don't observe it as much. And truly, if we're talking about receiving that medication, then in both men and women, there's sometimes a hormonal therapy that's given ahead of that kind of can help preserve fertility when exposed to that medicine, which is called Lupron.
But I'm not sure if that affects the men in any way, the Lupron, but I'm not so sure about that. I haven't looked into depth with that, but again, it's not as concerning as female, I would say.
Okay. Can identifying genetic causes of lupus improve treatment of diagnosis?
So it's another kind of interesting question, and I think that right now, so most lupus is what we call a polygenic disease. So there are likely many, when we're talking about genetics, we're talking about like mutations in DNA that lead to certain outcomes in real life. And there is probably a partially genetic basis for lupus, because we see that autoimmunity and lupus kind of clusters in families and that kind of thing. Right now, because most lupus isn't coming from one gene mutation, it's really not common for anyone to get genetic testing for lupus. And similarly, at this moment, we don't necessarily know whether certain genetic types versus others are going to respond better to medication, to treatment in general, than other people. So there may be a time in the future when, especially when we're able to select and tailor a medicine choice to a person based on their genetics. We're really not in that era of treating nearly any disease outside of maybe some breast cancers and other hormonally related cancers. Lupus isn't there yet. As far as detecting it, like I said, it's mostly not done. There's some very rare testing in young children where it's like 1 or 2 genes mutated in lupus, but likely not going to influence diagnosis in real life for most of you all.
Okay. Any advice on how I can talk to my rheumatologist better?
I don't know how to answer this. Hey, you know, it's very important to have a good trusting relationship between you and your doctor. And if that doesn't exist, perhaps looking to different doctors, sometimes it might help, you know, to try to get a physician that you trust and, you know, develop that mutual relationship. So be open, be honest about adherence, about the medication, about all the medical problems. We're very rushed sometimes in clinical settings because, you know, we see patients within a strict, you know, limited time frame. But there is many different ways to communicate through messaging, through telephone calls, through, you know, even during the visit, bring up your most important points. See, like, be very straightforward about your concerns with the doctor. Ask questions as much as you can. It's very important to understand in order to be adherent with the medication. It's important to understand how it works, why. So all this should be discussed very openly, but I don't know how to better answer this. So
we hear a lot of, you know, drug companies and stuff talking about journaling. Do you like that when, you know, people bring a notebook, or does that help? Or
that would be a little time consuming. So as I said, I think I prefer direct communication, just discussing with the doctor. I don't think oftentimes we don't find enough time to look through journals or read through journals. So I think, you know, your most concerning points, you should bring it up during the conversation.
All right. Next one. Is lupus contagious?
So that's a pretty simple one. No. When we refer to contagious, we're really mostly referring to infection, something that you having the condition will influence someone next to you getting it. And no, lupus isn't an infection. It's what we call an autoimmune disease. And it comes from your immune system mistakenly attacking your DNA and causing a variety of different problems in different organ systems. And while there's a genetic basis that means that it clusters a little in families, it doesn't mean the same as you can give it to someone else. You simply can't.
Okay. If I have been in remission for a long time, does that mean I'm cured?
Okay, so we oftentimes say there is no cure for lupus, but it can go into remission. I mean, the disease course itself could be benign, could go into remission with or without medication, just like Dr. Cherney mentioned. But if you've been in remission for a long time, less likely, you know, the longer the time that you've been in remission, the less likely you're going to reactivate or go into like a active disease state again. But it's important to stay in touch with the doctor, to do frequent blood work and monitoring for symptoms, so we are not caught off guard and we don't see that lupus came out of the blue again. But I would say the longer it's been in remission, the less likely it's going to come back. And so you can say it went into remission. I'm not sure if we could say it's cured, because there is no cure for lupus.
Okay. If I have lupus, what other autoimmune diseases might I get?
So the answer to that is basically that your risk of any other autoimmune disease is higher than it would be for someone who doesn't have autoimmunity. And the same is true for having any other autoimmune disease, at higher risk of having any other autoimmune disease. So autoimmunity doesn't always behave like a textbook. And so one thing we know is that when the immune system mistakenly recognizes you as an enemy, or parts of you as an enemy, it may manifest that in a variety of different ways, which may then look like certain diseases. So to give you a couple other names, but this is not even close to the full list of things that are possible, you know, rheumatoid arthritis, psoriasis, Graves' disease of the thyroid, or Hashimoto's thyroiditis, inflammatory bowel disease, really like type 1 diabetes, etc. The list is very, very long.
All right. Is lupus worse for people who are older, like over 60, or younger, like under 10?
I think lupus is rare to happen in over 60. I mean, you can see it at any age, but it's a disease that affects younger female in general. So, and the younger the patient, I mean, the disease can be severe at a young age, but also you accumulate more organ damage over the years, either from lupus itself or the medication. So say beginning at a younger age makes you a higher risk for severe disease and more organ damage accumulation over the years. So I would say it's more severe when it starts at a younger age.
If a person with lupus has vital organ damage such as kidney, liver, or heart, which doctor is in charge of the patient's overall health?
So I think that has some room for interpretation. Most lupus patients, I should say, really should also have a primary care doctor to look after common things and screening and things like that. It's quite difficult for one doctor to handle all elements of lupus care. When lupus is limited to a single organ, let's say it is just in the kidneys, that sometimes happens, or predominantly in the kidneys. At that point, sometimes it is the kidney doctor that takes the lead on many issues. But what I'd say overall, what happens in real life for most people with lupus, they have some different elements of lupus, and they may affect different organ systems and produce different symptoms. The rheumatologist is probably responsible for most things that lupus touches, and it does kind of turn into most people who have lupus see their rheumatologist as probably the quarterback who coordinates among different specialists. But like I said, I don't think that means a lupus patient shouldn't have a primary care doctor to handle general needs. When you're seeing multiple specialists, your rheumatologist is really, like I said, going to be taking the lead in terms of coordinating between people to produce a kind of consensus opinion. So it's really us. You should have a primary, and sometimes when it's organ limited, it's that specialist.
Okay. Does a person with lupus need to be concerned?
I tell my patients all the time, having lupus doesn't exclude you from all the other medical conditions and routine screening and health related concerns. So it's nice to have a primary doctor to be in charge of overall health, although we as rheumatologists are in charge of coordinating lupus care. So,
okay, that makes sense. Does a person with lupus need to be concerned about being exposed to high altitudes in areas such as Denver?
Not necessarily, I wouldn't say, but lupus sometimes can affect the lungs as well. So in different ways, people with lupus can have pulmonary artery hypertension or other lung involvement. And if there is lung involvement, they should avoid that. Or if there is certain blood abnormalities, but in general, just having lupus shouldn't be a problem to prevent you from high altitude areas.
All right. And then we have one last question that came in, and we will have a few extra minutes. If anyone has any last questions, you want to add them to the comments, we can ask before we log off tonight. But the last question that came in was the COVID vaccines. How many for people with lupus should they have taken? And are there more that we should be taking? What are the recommendations for wearing masks and social distancing?
So this is a question that the answer changes pretty frequently, and because the guidelines continue to be updated by the CDC. The overall trend, I'll say, for COVID is that the newer variants are traditionally less severe. We're not seeing as many deaths even in immunocompromised patients, which means that probably the marketing for the vaccinations has kind of gone down over time. We'll usually use the CDC recommendations, which are available on the CDC website, to determine number of vaccines. Right now, they're mostly focused on administering what's called the bivalent vaccine, which is basically against Omicron and some of the newer variants of COVID. The old vaccine doesn't work on what's really around for most people now. So what they recommend there is essentially, from what I was looking at earlier today, essentially 3 shots in someone who is immunocompromised. That doesn't mean if you're on Plaquenil, because that actually does not immunocompromise you. But if you're on anything else, essentially in the lupus world, then 3 vaccines separated by at least 4 weeks between vaccines with the new booster. And they don't really care too much about what you did before that, because like I said, what you did before that likely isn't influencing what's out there now to any significant extent. So it's the new booster, Pfizer or Moderna, with the bivalent vaccine, which is really what's available everywhere.
All right. And then do you guys recommend wearing masks still, social distancing, any other precautions that someone with lupus who, still is concerned about COVID?
Yeah, so definitely an area that would be kind of debated even in healthcare at this moment. So for a person who's severely immunocompromised on really serious lupus treatments, any infection can pose a potential threat. We don't necessarily see that exposure to COVID necessarily is going to be like out of proportion to other viral infections at this point that you'll get. But probably at any point, it makes sense to wash your hands. Probably if you're immunocompromised, it makes sense to, in public, try to keep a distance. And if we're talking about masking, I mean, to some, like even in the hospital, we've stopped making it mandated for healthcare workers and patients to be wearing masks. That means that from your standpoint that, more stuff is going to be floating around. And if you're heavily immunocompromised and you're concerned, that means that you should really be wearing an N95 mask. If you're wearing a traditional droplet mask, it more protects others from you than you from others. So if you're concerned and you're immunocompromised, I'd still encourage you to do that. We are not mandating it. We're not pushing it on people anymore. And really the reason is simple, because the COVID infection over time has become less severe in people. But really, immunocompromised patients can get infections, and you should take measures to try to prevent them, because that's a serious source of bad stuff that happens to lupus patients.
All right. So we did get a question in the chat from Charles. Can the combination of medicines from various issues faced by patients cause a problem to the patient?
Yes, of course, the medications we use to treat lupus, they all have their own, side effects, and especially the combination of medication can amplify those side effects. So it's extremely important to monitor frequently with blood tests. Certain medication can cause drop in blood count, so does lupus itself. So it's even more important to monitor more frequently with blood tests to make sure there is no bad combinations out there, or hydroxychloroquine for that matter. Although it's a very benign medication, can cause like certain arrhythmias if it's combined with certain other medications. So it's important to know a list of medications and monitor frequently for side effects related to the medications.
All right. Are there any other questions? Because I think we have wrapped up our list for the night. All right. Well, nothing's come over, so we can just wrap it up, I guess. So we'd like to thank both Dr. Charney and Dr. Nika. Oh, one question in. Sorry. Oh, it's a question. Thank you, doctors, for being on this evening. Wonderful having you, seen a high percentage of female patients with lupus and, I don't know how to pronounce this word, do you guys see the questions?
No, where is it?
We can see it.
Comments.
There we go.
So thank you, doctors, for being on this evening. Wondering, have you seen a high percentage of female patients with lupus with antiphospholipid syndrome have successful pregnancies? If so, what made it successful? If not, any alternatives? I can answer. I mean, we can both chip it. But yes, patients with antiphospholipid antibody syndrome are at a higher risk for miscarriages or a higher risk for pregnancy complications. We have made it a habit of checking antiphospholipid antibodies in everybody with lupus, so we know the antiphospholipid antibody status. If someone is antibody positive with antiphospholipid, we consider that a high-risk pregnancy. There's certain other antibodies that can cross the placenta, can cause problems during pregnancy. But with antiphospholipid antibodies, we refer them to high-risk OB, and certain times they need precautions to prevent pregnancy losses, such as aspirin or stronger anticoagulation, depending on the history of prior miscarriages or other blood clots. So yes, antiphospholipid antibodies are higher risk for pregnancy loss. It's considered a high-risk pregnancy, and certain precautions need to be taken during those cases.
All right, and then we have another question here. Can masks be worn more than once safely? If more, what are the limits?
A little difficult to answer. I think it depends on the integrity of the mask and what kind of mask we're talking about. The more durable the materials are, the more they're able to be reworn. We tend to think of some of the droplet masks, the more common ones that kind of go on your ears and pinch over your nose like that, are not necessarily single use. Sometimes within a day we'll reuse them. Usually over multiple days they'll be worn down and they'll probably lose their ability to do their job. Most N95s are made a little bit more durably. So I think that it sort of depends on what it's made of and what you're trying to, like I said, prevent. Like if you're trying to protect others from you, those droplet masks are usually sufficient. And if you're trying to protect yourself from other people's infections, truly an N95 is sometimes needed.
All right. Well, thank you so much again for tonight and for hopping on and giving us all this great information. I know I learned a lot. I'm sure everyone else did. So thank you so much to Dr. Cherney and Dr. Nika from the Rush Lupus Clinic. So thank you everyone again for hopping on. One more thank you to the doctors. So we hope to see you guys next week. We have another live lupus event on the 30th with learning about resources that LSI has. So thank you again to everyone and have a great night.
Thank you.
Thanks for having us.
Thank you.
Thank you.